Hi, my name is Michelle Kozeniecki, and I'm the lead clinical dietitian at Froedtert Hospital in Milwaukee, Wisconsin, where I cover the medical and liver transplant ICUs. Today's course is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today, we're looking at supplemental parenteral nutrition in the critically ill adult patient. Our objectives today are to define and describe supplemental parenteral nutrition, review guideline recommendations for the use of SPN, including the indications and optimal timing for initiation, and to evaluate clinical and functional outcomes associated with the use of SPN in the adult critically ill patient compared with the use of enteral nutrition alone. Before I talk about supplemental parenteral nutrition specifically, I think it's important to talk about the relevance and importance of nutrition therapy in the ICU. An estimated 33% of hospitalized patients are malnourished on admission. Unfortunately, only about 8% of these patients are identified and diagnosed with malnutrition. On top of that, almost 70% of patients experience a decline in nutritional status during their hospitalization. This is really important because we want to make sure that we're finding these patients early enough to do something about it. Septicemia was the most common principal diagnosis among malnutrition-related inpatient stays in 2016. And this speaks to me because working in the medical ICU, these are many of my patients. So talking about the impact of malnutrition, these patients are at increased risk for worse outcomes compared to those who are well nourished. This means that they're 2 to 3 times at increased risk for developing C. diff colitis, surgical site infections, or post-op pneumonia, 4 times more likely to develop a pressure injury, which is considered a never event, 5 times more likely for mediastinitis, which is an infection after CABG surgery, and 5 times at increased risk for catheter-associated urinary tract infections. Furthermore, mortality ranges from about 4 to 11% in malnourished patients versus those without malnutrition, which is only about 2.4%. So once we find our patients who are malnourished or at risk for developing malnutrition, what can we do about it? Let's talk about those nutrition therapy options. The first option is, of course, enteral nutrition. And this is a table looking at the guidelines from Canada, the Society of Critical Care Medicine, and Aspen. And these international guidelines, in general, agree that enteral nutrition is the preferred method of nutrition therapy whenever it's possible, and generally within 48 hours. And this is because it's more favorable in terms of physiologic response. So it maintains gut integrity, modulates stress and the systematic immune response, and it attenuates disease severity. There are some problems with enteral nutrition, however, and that has to do with the frequency of interruptions. So several studies have found that enteral nutrition is held on average up to 8 hours per day in the ICU. Even in my own ICU, these are the reasons that we found for tube feeds being held, including anticipated extubation, many types of procedures, loss of enteral access, measurement of residual volumes, hemodynamic instability, and the list goes on and on. And this results in ICU patients receiving only about 59% of prescribed daily calories for the first 12 days in the ICU. And this is a big deal. So then we have to think about what are the indications for parenteral nutrition. Well, this is generally used for patients whose GI tract is non-functional or non-accessible. So this includes patients with short bowel syndrome, bowel ischemia, a small bowel obstruction or paralytic ileus, severe enteritis, high output enterocutaneous fistula, failed enteral trials, and varices or ascites or other reasons why a feeding tube can't be placed. But there is increasing focus on providing parenteral nutrition when the GI tract is technically functional, but we can't really meet those nutritional requirements orally or enterally. There's also increased focus on providing PN earlier for patients who are malnourished or at high nutritional risk. So let's look at the guidelines for when to use parenteral nutrition. In 2017, the Aspen PN consensus recommendations echoed this. And in 2018, the Aspen guidelines stated that PN should be implemented within 3 to 7 days when there's a contraindication to oral or enteral nutrition. They also added that early and progressive PN be provided instead of no nutrition when you really can't provide enteral nutrition to severely malnourished patients. So moving on to supplemental parental nutrition. In 2016, the SCCM and SPN guidelines recommend that patients who are at either low or high nutrition risk receive supplemental parental nutrition after 7 to 10 days if they're unable to meet 60% of their energy and protein requirements by the enteral route alone. In 2017, however, this was separated a little bit more into low nutrition risk and high nutrition risk. So for those who are well nourished and stable, but they're unable to receive full or at least 50% of their requirements for 7 days, that's when you should start supplemental PM. But for those who are at high nutrition risk, you should initiate PN within 3 to 5 days. In 2018, the SPN guidelines then recommended to avoid overfeeding with either enteral or parenteral nutrition, especially in the first 3 to 7 days. But then for those who don't tolerate full dose EN in that first week, that's when you should really individualize PN therapy. So what really is supplemental parenteral nutrition? Well, this was originally proposed as more of a rescue therapy to meet 100% of energy and protein needs, as measured by indirect calorimetry for calories, when enteral nutrition fails to meet energy needs by day 4 of ICU admission. There's a little bit of a difference in the literature, though, so let's talk about what we're going to see. First, traditional supplemental parenteral nutrition is when you're going to wait at least 3 days from hospital or ICU admission and only start supplemental PN if at least 60% of enteral nutrition is not delivered. So this means that you always have enteral nutrition present and then you add PN if needed. And then there's a newer concept that's being applied to some patients, which is initiating parenteral nutrition at hospital or ICU admission with or without enteral nutrition until at least 80% of goal is met from enteral nutrition. So my goal today is to talk about some of these studies. Starting with the SPN trial in 2013, Heidegger and colleagues looked to optimize energy provision with supplemental parenteral nutrition to improve outcomes of ICU patients where EN alone was insufficient. So their primary endpoint of this study was looking at nosocomial or hospital-acquired infections from day 8 to 28. They also had some secondary endpoints, including days of mechanical ventilation, length of stay, mortality, renal replacement therapy, and blood glucose levels. This was a 2-center randomized controlled trial where on day 3 of ICU admission, patients who received less than 60% of their energy target at that point were either randomized to continue enteral nutrition alone or to receive enteral nutrition as well as supplemental parenteral nutrition for 8 days. These patients had their calorie targets determined by indirect calorimetry or using 25 to 30 calories per kilogram of ideal body weight. For this study, the results showed that the adjusted probability of nosocomial or hospital-acquired infections between days 9 and 28 was lower in the supplemental parenteral nutrition group. So that is the red dotted line on the right of your screen. There was no increase in the number of bloodstream infections in the SPN group, and you can see that on the table to the right. The mean number of antibiotic stays was significantly lower in the supplemental parenteral nutrition group, and the mean number of antibiotic-free days was higher in the SPN group. They also found that there was no difference in the duration of mechanical ventilation, length of stay, ICU length of stay, hyper or hypoglycemia, renal replacement therapy, or mortality. Moving on to the top-up trial by Wishmeyer et al. In 2017, the objective was to increase energy provision in adult ICU patients with supplemental PN with the intention of improving 60-day survival and quality of life versus enteral nutrition alone. Their primary endpoint here was to achieve an increase in calorie and protein delivery by approximately 30%, and that was to achieve separation in groups. They also looked at secondary endpoints, including mortality, infectious complications, duration of mechanical ventilation, and length of stay. This was also a multi-center randomized controlled pilot study where ICU patients with a BMI less than 25 or greater than 35, so these are the patients deemed at higher risk, were randomized to receive either enteral nutrition or enteral nutrition with supplemental PN. Both groups, again, were prescribed the same amount of calories and protein, which were different by BMI groupings. The results of this study showed that provision of supplemental PN plus EN significantly increased calorie and protein delivery versus EN alone, so they did achieve their primary endpoint. And then they found no significant difference in major clinical outcomes. So no increased rate of suspected or newly acquired infections, which you can see that in the table to the right. And they also found potential trends and tendencies. So reduced hospital mortality in the supplemental PN and EN group in high nutritional risk patients, so that was their study group, and improved hand grip strength at ICU discharge in those receiving supplemental PN. So this is starting to look at functional outcomes. It's important to note that this trial was not powered primarily for clinical outcomes, but they did assess these to help guide definitive trial design and assess for clinical signals to justify a larger trial. Moving on to the Ridley et al. Study from 2018, the objective here was to determine if individualized supplemental PN would increase energy delivery and meet energy requirements for ICU patients compared to those receiving enteral nutrition alone. The secondary aim was to determine rates of enrollment, feasibility of trial processes, and estimate sample size, again to plan a larger RCT. So this again was a pilot trial. Their methods was a multi-center randomized controlled pilot study where ICU patients were randomized within 48 to 72 hours after ICU admission to receive either enteral nutrition alone or early supplemental parenteral nutrition for 7 days. Both of these groups, again, were prescribed the same amount of calories, which was 25 to 30 calories per kilogram. These authors also found that the provision of supplemental PN significantly increased calorie and protein delivery compared with usual care, in other words, enteral nutrition alone. And there was no significant difference in duration of mechanical ventilation, ICU or hospital length of stay, mortality, or witness complications of feeding or functional outcomes. Lastly, I'd like to talk about the systematic review and meta-analysis of 5 high-quality randomized control trials, which included studies comparing supplemental PN and EN with EN alone. So this is a little bit different than other meta-analyses that might have looked at early versus late supplemental PN. And this is strictly SPN plus EN versus EN alone. The results found in this meta-analysis were that enteral nutrition plus SPN results in higher mean values of energy and protein intake when compared with EN alone, which is what we saw in these previous studies. No significant difference in the mean values of duration of mechanical ventilation between enteral nutrition with SPN versus EN alone. And the risk of occurrence of infection was reduced by almost 27% with EN and SPN compared to EN alone. There was also no significant difference in the mean length of ICU stay, and the risk of ICU mortality was reduced by 43% with SPN compared to EN alone. Once you start supplemental parenteral nutrition, then I think it's important to also talk about how to wean it. So you want to continue to evaluate enteral nutrition tolerance daily, as well as looking at how to optimize enteral nutrition tolerance and increase delivery. Then you want to adjust PN daily to avoid overfeeding of total calories between enteral nutrition and supplemental PN, and discontinue supplemental PN when your enteral nutrition is providing at least 60% of measured or estimated energy requirements. So I'd like to summarize here. Indirect calorimetry is recommended to determine caloric targets to avoid both underfeeding and overfeeding. Adding supplemental parenteral nutrition to EN could be beneficial to decrease the risk of ICU mortality and nosocomial infections with no adverse effects on other clinical outcomes. Supplemental parenteral nutrition should be delayed until at least ICU day 4 to allow enteral nutrition to progress sufficiently. And you want to initiate PN as soon as feasible in malnourished or nutritionally at-risk patients. And as we know, more research is needed to strengthen clinical practice recommendations. As we see, we have a couple pilot trials, and I'm looking forward to seeing the definitive trial designs and published research. So I hope you found this program beneficial to your practice, and I would encourage you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Thank you and have a great day.